Good evening, everybody.
Hey, BJ.
Thank you, Chris. I keep trying to get Abby to say hi to me, but she won't. Even though she sits on my floor. And I've decided to pick on her today for that. Anyway, welcome to all of you at our Idea Exchange in Digital Healthcare. Just kind of a few words of welcome. So this is the fourth year the center has been around, and we're just delighted that all of you continue to join us. And delighted to see so many old faces and some new faces as well. Before I sort of start talking a little bit about digital healthcare, I do want to say a couple of things. One is we would love for you to fill out our evaluations. We actually also have, Megan will tell you about the Twitter feed that we're running today. Feel free to post your questions and comments and broadcast. We've seen the effectiveness of Twitter in the political campaign these days, and that's all I'm going to say about that. Thank you all for joining us. And the thing I'm most excited to announce is our signature conference on March 24th, 2016. We ran the first conference this year. It's called Road to Reinvention, Leadership in the Digital Age. We decided to use the same name every year. That way we don't have to think of a new name every year. We just add a new year at the end of it. And we really lined up an amazing set of speakers who will be sharing their expertise and experience and insights with us. So for example, we have Bill Rue, who is the CEO of GE Digital. So he's GE Digital is the first new division that GE has launched in the last 40 years. They want to be one of the world's top 10 software companies. And he's also the Chief Digital Officer for GE as a whole. So this is an industrial company that is leading. It was founded in the days by Thomas Edison, and it's now sort of leading the way to the digital revolution. We've got the SVP of Digital Customer Experience of Disney, and a variety of others. You can look it up on our website. But it will be, I think, a fascinating day. We encourage you all and invite you all to attend. So with that, let me turn to sort of digital healthcare. And as I've said before, education and healthcare are the two sort of slowest productivity improving areas of the economy. And both our industries are being sort of dramatically disrupted by digital technologies, which is why, if you look at the market valuation, I'm jumping a little bit, if you look at the market valuation for Udacity and Coursera, these are huge market valuations. These are unicorns now, $1 billion plus valuations. And so there's a lot of disruption coming our way. Healthcare is really sort of being transformed in very, very interesting ways. I was at a conference in San Francisco a couple of weeks ago called The Next Economy, and they were showing us how MD Anderson is using IBM Watson for cancer diagnosis and treatment. And some of the stuff that's going on in healthcare is absolutely amazing. And obviously we've got superb panelists who are going to talk about this today, so I'm going to save that. But we're also especially delighted that Dr. Howard Federoff, the Dean of the Medical School and Vice Chancellor for Health Affairs, graciously agreed to moderate this panel. He is, of course, one of the world's foremost experts in neurology. I always thought that my sort of academic career was long, because it exceeds ours. Anybody who's done MD, PhD has been in school for an awfully long time. As you know, anybody who's in the healthcare space these days is extraordinarily busy, and so we're always delighted when they graciously agree to sort of spend their time helping us sort of improve our practices and our state of knowledge. So, and the last comment, I want to thank you to my team of Debbie and Megan who kind of put these events together. And Sam King is our industry fellow in digital health, and is the one who sort of has the healthcare expertise and really kind of helps us put these programs together. He's invaluable support to the center. And he's an alum and just volunteers this time extraordinarily graciously. So thank you, Sam. With that, Dr. Federoff, let me turn the floor over to you. And thank you again for your time and for
Thank you. Well, good evening, everyone. It's a pleasure to be here and to participate as the moderator for this evening's panel. So there's a lot that's going on, and I think we'll just cover part of the landscape this evening and really invite all of you to be part of that conversation. It gives me a great deal of pleasure to introduce our keynote speaker, Dr. Benjamin Chu. A very distinguished career, and I'll only cover some of the highlights. You can see that he has a really wonderful portfolio of responsibility, being responsible for 14 hospitals and 237 medical offices as part of his remit for Kaiser. But Ben has done a lot more. He is a dyed-in-the-wool academician, having spent time, like many of us, in academic medical centers and NYU at Columbia. He also led, as president, the largest public hospital system in New York, in the country, in New York City. In addition, he has an interest in public health and was the acting commissioner of public health for New York City. When you bring together that set of skills, it makes clear why someone who's looking forward needs to think about what technology is going to enable, delivering better, smarter, more precision, and ultimately higher value care. And so we are delighted today to have Dr. Chu as our keynote speaker, and after he finishes, I'll introduce one of our panelists, and then we will have a structured, moderated discussion amongst ourselves, but again, we invite you. Dr. Chu, welcome.
Thank you. Thank you, Carl. Thank you very much. I really thank you, DJ, for inviting me. I can't think of a better topic to talk about the Center for Digital Transformation, because, what I want to talk about is, I've been at Kaiser Permanente now for just coming on to the end of my 11th year. And in that last decade, we've really done a lot of work and utilizing digital tools in order to get to where we are today. Some of you guys many of you are from California, so you know Kaiser Permanente pretty well. And I've always read about Kaiser Permanente, but one of the reasons why I came to Kaiser is because you think about how the system and the delivery system is configured. It's really a virtuous collection of a payment system, a physician organization, and a hospital system with prepayment as the mechanism. So we're not tied to fee-for-service as a mechanism to gather the dollars to do what we're doing. So from my vantage point from New York, it was a system really built for performance, right? Just totally built for performance. And yet, when you look at the Kaiser experience and the Kaiser delivery system about a dozen years ago, it was a good system, but it was by no means, leading the pack. I mean, think about, and I can tell you, when I first came out here, people were really nice to me. I told them I came to be the president of Kaiser Permanente, and then invariably, I used to call it the cocktail party test, right? They'd be very nice, and then all of a sudden they tell you about their Aunt Susie or their so-and-so, and this kind of experience. It got to the point where I just never went out. I mean, for a while. But now I have to say that the difference, and this is really scientific, I know, but the cocktail party test is completely different. We are, when I go, I tell people where most people are actually pretty happy with where we are. And the thing about it is that my area really is Southern California, although I have some responsibility for Georgia. And in the 10 years that I've been here, 11 years I've been here, we've grown 1.1 million members. So we went from 3 million members in Southern California to about 4.1 million. That may not sound like a lot from the health plan world, right? Because you hear about millions of people being covered, but when you actually have to deliver the care for 1 million more people over a 10-year period, that's a lot of infrastructure, that's a lot that you have to pull together. So what I want to do is really give you a sense of the journey over the last dozen years and begin to talk a little bit about the key ingredients. A lot of the key ingredients were digital in nature, but it's not just, when I first got out here, we were still paper-based, right? So, and not only were we paper-based, but the first care center I went to, they were actually pushing huge vats of x-rays, right? And you think about it, nobody ever sees x-rays anymore, but we were still a film-based system, a paper-based system in 2005. So the beginning years was really a digital transformation, but it's not just, when I say digital, I mean, we put in Epic, the electronic health record, and actually did digitize all of the imaging infrastructure. So we're actually completely digitized now. But it's not just about putting in the tools where you take the paper record and you flip it into a computerized format is really what you do with that information and how you actually use that information to drive systems changes and delivery system changes that's transformative, right? It's, so the key is that these computer systems and the various digital tools that we put in are simply that, they're tools. But how you configure it and how you drive for the ultimate goal, which is really to improve the health of individuals and the community, that's the key, right? And that's the nugget in what I hope to impart to you. So I want to talk about key factors that facilitate taking innovation to scale at the Kaiser Permanente system, particularly the Southern California experience. I mean, really, if you go to Northern California, it was a parallel trip, but I actually just know Southern California so well. And it's also talking about taking to scale quality and service improvements, because when people told me the stories about their Aunt Susie, they were talking about quality concerns or service concerns or problems that people had in getting access to care or getting care that they thought was really what they expected. And then finally, if we have time, I want to talk a little bit about where we're going. I want to talk about a framework, because one of the incredibly exciting things about where we are now is that there are a lot of tools out there that we're not even thinking about. I think BJ's absolutely right. Healthcare is one of the slowest places for using new tools to transform. But if you actually think about the tools that are there, and I'm not talking about supercomputers like Watson, I'm talking about core digital tools that are every day now. How do you actually apply it so that you can actually make a bigger difference in getting people to live a healthier lifestyle and to get better outcomes, right? So let me just go over this a little bit. But basically, what I think that are the key take-home points is, what we've tried to do in our journey is to have an intentional focus on how you use information to drive the systems changes to improve individual and population health. And of course, the important point is how you actually use this to engage with patients and members, right? Because you can have all the bells and whistles, but if there's no way to interface with your members in a very positive way, you're never going to get the results. And then the new paradigms that we're trying to bring in are to try to figure out how to take our system and move upstream to really deal with the social determinants of health, as opposed to just the medical determinants. And then finally, one of the key cultural things that we're working on is creating the environment where transformation becomes an essential vehicle for meeting our mission, right? So, in a lot of ways, if you look at healthcare, one of the problems that people have, particularly those of us who actually implemented electronic health records, is that it's a push. We're pushing it out there. We're telling our doctors and our nurses, this is going to be great for you. This is the best thing since sliced bread. And of course, everybody's cynical right there, and they think, oh my God, I have to learn a whole new system. What do you mean? I can't even get it to work. And all on and on and on. You can imagine that. But how do you actually configure the systems and the information that's there so that people, instead of fighting you in terms of trying to how to utilize these systems, how do you get them to want it, right? How do you get them to say, what more can I get from you? If I only had this, I could go much, much further. That's the push versus pull. And it's sort of a magical point when you can get people to say, I want more, because I could actually do more. I could get a better result if I had this happen. And I think hopefully you'll see by the end of the talk that we've actually embarked on this journey. Just a quick note. We are we're the oldest integrated delivery system in the country. We came into existence about 70 years ago. We are now serving, actually the last count, it's about 10.3 million people across 9 states and actually 8 states in the District of Columbia. The largest regions, of course, Northern and Southern California. Southern California is the largest region, and just to put it in perspective, 4.1 million people in Southern California. In the area that we cover, the area we cover roughly has about 20 to 21 million people, right? From Kern County down to San Diego, and from West Ventura out to Coachella Valley. So if you actually think about it, this is I think about this sometimes, and I'm just totally floored. If I looked at a group of people, almost one out of every 5 of you would be a Kaiser member. I'm not going to ask you to raise your hands, embarrass you, but statistically, 1 out of 5 is a Kaiser member. So we either do a great job and people love us, or we better get out of town because we're so it's a big responsibility to take care of that many people. We made a $4 billion commitment to Epic when we implemented Epic, but it's not Epic that helped us do this. I mean, we actually, on top of Epic, had to build lots and lots of different population care management tools that allowed us to do this. Next year, in Southern California, will be about $24 billion in prepayment. So it's a lot of people. It's a fairly sizable chunk of change. But the nice thing about it is that we can actually figure out how to direct out those dollars in a way that can hopefully help us optimize the health status of our communities. Many of you, I don't know how many of you are actually actively in healthcare, but the healthcare world has embraced Donald Berwick's formulation of the triple aim, right? That really the purpose of the healthcare system and all of the money that we spend should be on improving the health of our population, improving the care experience, the individual experience, and focusing in on value and cost efficiency. I'm not going to go into how much we spend on healthcare, but if you saw recently, we've now topped $3 trillion. So it's about 18% of GDP for healthcare. So the question is, are we actually getting better health and better health of the population, and are people's experiences really worth the dollars that we're expending? These are the key success factors, as far as I can tell. A full alignment and integration of the delivery system and the payment system. That's our model, right? Prepayment. Meaningful, real-time, and actionable quality and performance information, right? And that's really important. It has to be real-time in order for you to be able to act on it to get better results. Transparency of performance, especially for physicians, using both internal and external benchmarks. I think clear and unambiguous leadership direction. I mean, one of the things that we started to focus in on a decade ago is quality and service was what we're driving at. Even though I'm the health plan executive, I rarely talk about finances. I honestly rarely talk about it. Really focused on quality and service as the key driver for where we needed to go. And I figured that the finances will take care of itself. Of course, it was helpful that when I got here, we were still in a sort of a hyperinflationary period where premiums were going up quite a bit. So there was always enough money to go around, but I'm not going to tell you, I'm not going to talk too much about that, but really it was the focus on quality and service. And then I think the willingness to leverage every aspect of the delivery system, taking advantage of the information that we got to drive for better health outcomes for individuals and for the population. That's the key. So what did we do? I mean, just very quickly, Epic helped us a lot, right? But we also had information from our pharmacy systems. We had, of course, the demographic information and information from our labs, etc. Right? So what we did was we basically took all that information, and every every 24 hours, there's a data dump into, you know, a large data repository. And what we ended up doing was we scrubbed all this data with evidence-based algorithms to generate all these tools that you see here, right? So some of them are pretty basic tools that try to identify people where we need to send reminders out or lists of things for people to call. But basically, but really much more important, what we did was we actually customized that information for different aspects of the delivery system. So the doctors could get a profile of their patients. The chief of service could get actually the whole panoply of the population that is taken care of by their department in San Diego or elsewhere. So you can cut and dice this information in any way possible. And we put it on a web-based system, so that, and also made it available in a computer system. So when you actually sign on, you know, your screen actually gives you the ability to look at what's configured for your role in your job, right? And then what we are able to do is, well, let me go back for a second. What we're able to do is begin to wrap around our members, you know, really deep analysis of what the gaps are in what we could be doing for you to keep you as healthy as possible, right? So we scrub this database with evidence-based protocols, generate gap analysis for each individual, and then you can see how it rolls up into the population that you took care of, and started to devise tools that showed people where the gaps were. Okay, now, you know, if you, so that's great, because as a practicing clinician in the paper age, you couldn't possibly do that. I mean, there's just no way you could constantly audit your charts on a daily basis to figure out who's missing this, whose blood pressure isn't controlled, who has other kinds of needs that you haven't been able to address. But because we were able to do that with digital information configured in the way we did, we had these tools. But you know, one of the things that is, I think, is a mistake that people make is they'll say, okay, we have all these tools. The primary care medical homes is one of those, you know, one of the new fads where what people are saying is, give the doctors this information and things will be better, right? But you give the doctors this information and what do you get? Very depressed doctors. Really, you know, doctors get really upset because they can't do anything about it. You think about it, you have 2,000 people and we're telling you that on average, you know, there's 2.2 gaps per 2,000 people. That's over 4,000 things that you have to address. So on a daily basis, we're generating this information for you. What doctor could possibly address that? I mean, just think about how logically, you know, and by the way, when we started to do this in the beginning and handed it to the primary care doctors, they were getting very testy and depressed because they just realized they threw up with their hands and they would complain about it, right? And they forced us to think about, well, how can we actually work with this information, give it to the doctors, but actually make it everybody's responsibility for addressing these gaps. I mean, that's essentially what happened. And by the way, the other thing that was, we're a primary care-based system, but when we looked at, we did a little look at who amongst our population had the most number of care gaps, right? So it's a couple 100,000 people with the most number of care gaps. Well, guess what? 60% of them never even made it to the primary care doctor. I mean, does that surprise you? Actually, it shouldn't surprise you because, you know, how many of us go to the doctor on a regular basis? I mean, when you think about it, I'm not talking about people who are really sick and, you know, have multiple chronic illnesses. I'm talking about regular people who usually go to the doctor when they have something wrong with them, right? So when you think about the interactions that we have with our patients, it's by the way, the average number of visits in this country, and this is just raw average, that a typical American makes to a doctor is 4 times a year. And it's not just this, it's often not the same doctor when you think about it, right? And it's probably not surprising to you because, you know, I'm sure in your experiences, you know, you wouldn't see the doctor that often. So to think that the doctor, given this information, could actually impact that individual's health. And remember, the underlying premise of the U.S. healthcare system and really any delivery system is the sum total of all one-on-one interactions with any single member of the population. The sum total of all those interactions will lead to a healthier population, right? That's really how we fundamentally work. We think that it's episode of care oriented, but the sum total of all those interactions and all of the things that we can get you to do will lead to a healthy, not only a healthier individual, but a healthier population. And clearly, that doesn't work. If you actually think about that underlying premise, it's just nonsensical to think that you would get the optimum levels of health. You might get healthier, you might get, you know, have an impact, but if you're really thinking about truly impacting the health of the population, you're not going to get it done. That's not the way it's going to happen. So it fundamentally forced us to think differently about how we use information that we didn't have before, right? Because paper-based record, you couldn't possibly know what the care gaps are for 3 million people at the time, and now 4.1 million, but now we do. And then, what do you actually do with that information? So the digital revolution in healthcare provided us with a tool to identify, you know, different areas that we could actually work on, but how do you actually make it work? How do you actually get those results? Well, it turns out that, you know, if you're prepaid and you have the ability to direct resources to lots of different things, you know, you could build different tools and target it for different people to work on those, right? So, so that's what we did. So we have all these little programs that we've run, and what we do is we, you know, I mean, this is a typical medical way of breaking it down, right? Medical, surgical, OB. But basically, I think the tools are much more important. You know, how we wrap these tools around our patients, our members, and how we try to target, you know, the process of filling those gaps in care, right? So, for example, a typical population, typical population, 25% of the population, adult population, has hypertension. Some people think it's actually higher. But if you actually look at the most series of, well, what percentage of that population is actually controlled, where their blood pressure is controlled? And, you know, probably 10 years ago, it was somewhere on the order of 35% or 40%, right? So then we've gotten a little bit better now. So now maybe it's up to 50%. Well, at Kaiser, because of this intentional use of information and driving the patients to different systems to help get better gap closure, we're at 90% control right now. 90% of hypertensives are controlled. You know, and of course, some people, you know, there are disparities. African Americans typically have poorer control. Latinos are poor control. Well, we actually still have gaps between them, but they're all around 88 to 90%, even though there is a gap between African Americans and the dominant populations. So you can actually make an impact, right? And it's not like, and by the way, when I say 60% of the people with the largest numbers of gaps never made it to primary care, you know, we had to actually make it everybody's responsibility. So if you go to an orthopedics, sports medicine clinic and you have hypertension, we're not asking the orthopedist to actually treat the hypertension, right? God forbid we should do that, right, Howard? It would be a disaster. But we actually make it their responsibility to get that person to a nurse who can actually treat the blood pressure, right? And then there are lots of other tools that we built so that we sort of hound people until they're better controlled. So the cancer screening, I mean, think about colon cancer screening. Colon cancer is one of those diseases that's actually curable, believe it or not. Because if you actually find colon cancer in the pre-cancerous stages, it proceeds from a polypoid stage and morphs into cancer. But if you catch people in the pre-cancerous stage and you take out those polyps, you can prevent somebody from getting colon cancer. I mean, it's one of those things where, from a purely public health perspective, you can merge public health and the care delivery system and really make a big impact. Now, unfortunately, not everybody gets screened, and they're often not. We often find the cancers a little later on. So screening serves two purposes: finding cancers early, right, and/or finding the polyps before they become cancer, so you can get them. And if you do a good job, by the way, you should be able to see a decline in the prevalence of colon cancer. And that's one of the things that we were able to do. When I started, we were screening at 33%, 1 out of 3 eligible. 50 or older individuals are actually the population that you want to screen. And we were getting maybe a third of our older adults. I mean, I don't want to say elderly anymore. 50 is not elderly. Okay, 50 is the new middle age, right? So now we're up to about 82% screening, right? So that's a big jump. And when you think about the population that's 50 and older, you remember we now have 4 million people and over 500,000 Medicare Advantage members right now, 530,000 in Southern California. So if we get to that population and do the case finding and find early cancers or get to the polypoid stages, we should see a drop in the prevalence of colon cancer. I think I have a slide down the road to show you what that is. Oh, this is just a tool for the doctors. This is a doctor's screen, and it breaks down their panels into their individual patients. And we actually show, you can't really see this, but one of the columns shows you what the gaps are in their care, right? So it identifies that. By the way, the other thing that really was important was that we actually showed the doctor what their results are, but we actually showed every doctor's results. We completely unblinded this information. It's all on the website that any doctor can actually access. And rather than making it, punitive, right? Because you don't make it punitive, it's because it'll never work if you make it punitive. It actually just pointed out to the physicians who's actually doing a better job and who's actually taking a different systems approach that allowed them to get those results, right? So those are the kinds of things that we did. But doctors are naturally competitive. We're all type A personalities. And nobody wanted to, I mean, when you think about it, nobody wants to do a bad job, right? So if there's a pathway to get to a better job, this was a way to get people to really want it, right? So again, it's instead of the push, it's the pull. And everyone could identify with it. You control hypertension, the long-term rates of stroke and heart attacks and kidney disease go way down, right? They do. I mean, actually, our rates are probably 30 or 40% lower than the community-wide rates right now. And then colon cancer, the first time, and by the way, it's not just other doctors that we got to get these gaps, to try to address these gaps. If you called in to our call center to make an appointment, right? And they see in their screen that you, and we only, we try to target different things for different audiences. They'll see that you haven't had your colon cancer screening and you're of the age to do that. They'll try to get you in. So that first woman that we actually found with breast cancer, because the receptionist in dermatology clinic, saw this and wouldn't let the lady go before she had her mammogram. And when we found the cancer, we plastered that all over. I mean, it was actually made into a Kaiser TV ad at one point. So everybody could see that it's everyone's duty, but it's also everyone's, everyone's ability to actually participate in finding these things and making a difference. Of course, in the video, the patient was like crying and gushing about, the woman who actually just wouldn't let her go, and this was cancer, right? So it's just one of those emotional tugs that you can make it, you can, and that's why I actually like to talk about bringing back the joy to care delivery, because you actually go out there now, and so many doctors complain about how there's such drudgery in healthcare. Well, if you're actually making such a big difference, and you can prove that people are healthier, that that you're actually addressing things that really make a big difference, then how can you not feel joy in your job? Especially since it's not just your responsibility anymore; it's everyone's responsibility. It becomes a collective sense of pride in the results that you get. I'll just go through this. I pretty much went through this. So every part of the visit, pre-visit, we try to get at it, and we'll actually call people. We have IVR calls sometimes to remind people that we know are due for certain things. And it's just a much more comprehensive approach to it. And this just shows you the outcomes over the decade, right? So these are just some of the outpatient screening results. You can't really see it, but blood pressure control, cervical cancer screening, colorectal cancer screening, osteoporosis management. We probably have 40% fewer fractures amongst elderly women in Kaiser relative to the population, because we screen for osteoporosis, and we do a lot of work with them. It's true in the inpatient side. I don't really have a lot of time, but we took the same kind of systematic approach to inpatient patient safety types of measures, and have seen incredible increases in patient safety. And then the focus on patient satisfaction. Believe it or not, this is a lot more complicated. It's not just about giving people information. But we didn't make progress until we changed vendors, and people could see on a daily basis all of the patient feedback that was coming in. And we gave people online tools. I don't know if you know, but Medicare asks for this HCAP scores. It's essentially a service, a questionnaire that goes out to any beneficiary. Actually, it's not just Medicare. We send it to a commercial population, and they rate you on a whole set of dimensions of hospital care. And when I started out here, when HCAS first came in, I think it was a little later than 2005. We were at the 10th percentile on HCAP scores, which meant that 50% of our members gave us a 9 or 10 on a 10-point scale. And now, because of the focus that we've had, we're at about the 80th percentile. It's not where we want it to be, but it's a big jump. So, and that translates into about 78%. Giving us a 9 or a 10, which is actually pretty good. It's not the best, and obviously we want to do better. But you can see, and the point I'm trying to make is that if you take a very systematic approach and you give every member of your healthcare team the tools in which to do things, and of course, you have to give them some tools on how to actually make a difference as well. We've done a lot of work on culture. And on rounding. Some of us in the healthcare world know about Studer and the Disney model. We've done all of that stuff to get these kinds of results. But you go onto when I came on, going onto the hospital floor, then and now, it's like a world of difference. People are just so invested. And I think, that's one of the reasons why the cocktail party test has gotten so much better, because people are actually happier about their overall experience. And then, of course, you know, one of the things that we do, I mean, this may seem a little hokey to you, but there's actually some good epidemiological evidence to show that if you actually get these kinds of results on blood pressure control, diabetes control, it translates into lives saved. So we do this a lot. I mean, we'll just put it out there, you know, and we'll do hokey things like in the beginning when it was about 17,000 lives, we'd show a picture of you know, of the Staples Center, right, basketball game. Now we're actually up to a point where we fill a third of the Rose Bowl, and the goal is to fill it all. And this is really life savings, right? Because you know, if you don't have a heart attack or a stroke and you survive, people die of something. I know, but at least you're not dying prematurely of these kinds of illnesses. And cancer, colon cancer, I'll show you a couple of slides on colon cancer. Our survival rates are better. We get patients earlier on, so they come in at earlier stages. And remember what I told you, if you do good screening, you should see a lower prevalence rate. And in fact, we've had 35% drop in cases, right? And this is a 35% drop in absolute cases at a time when we've grown our Medicare population by 200,000 members. So it's a much more astounding drop than you might think. And the 5-year survival rates for cancer are better. And this is a goal that we put out there, that not only are we going to try to drop the prevalence of colon cancer, but we want an absolute drop in death rates from colon cancer. And this is the last 3 years, right? So year 2 is actually 2014. So, and we actually are seeing, believe it or not, our goal is to cut the death rates from colon cancer in half, and over a 10-year period. And in the 3 years, we've seen a drop from 13.8 to 11.9, right? Which is a combination of earlier detection plus, and these are actual colon cancer cases, earlier detection, getting people at an earlier stage, and more effective treatment. This is just an example of systematically looking at foot exams and amputation rates. So, you know, they're just examples of how a systems approach can get, using good data, can get to better results. This is, I just wanted to go over this one other thing. One of the things about healthcare is if you're ever in practice as a physician, one of the worst things that happen is when you discover somebody falling through the cracks, right? Do you know what I mean by that? You know, where you found something, you think you've referred somebody for follow-up care, and then 2 years later they come into you and there's a metastatic cancer somewhere, right? Because for one reason or another, they fell through the cracks. Well, you think that at Kaiser, you know, people wouldn't fall through the cracks, right? But when I first got there, we were every so often we get this case of a PSA that was high, that didn't get followed up, and then we get sued because somebody came in with a high-grade prostate cancer, right? And it wasn't a lot, but it was enough. So it was irritating to me that, you know, we should be an integrated system. We should be able to keep track of people like that. And the truth is that you can keep track of people if you look for it. You have to figure out how to do it. But if you actually think about digital systems, electronic systems like this, it should be very easy to generate lists of people who are falling through the cracks, right? It's just a simple if-then hypothesis. If you have this result, do you have that, right? So we've been building these if-then hypotheses. So if somebody had a high PSA, did we get the final resolution? Do we have confirmation of what it was? I mean, if you were found to have an enlarged aortic aneurysm, have we followed you up on a regular basis to prevent you from having a catastrophic rupture, right? So you can sort of get that sense of what we're talking about. Or if you had blood in your stool, did you actually have a follow-up to see if there was a cancer brewing in there? I mean, that's another thing that happens very often. People get lost to follow-up, and they come in with colon cancer. So we built a whole set of these tools, and believe it or not, we dropped all of those lawsuits. I mean, I can't say that everybody, there's nobody that falls through the cracks, but I can pretty confidently say that in with the tools that we've built, and we've built about 38 of them right now, and generated lists of people who were falling and intervened so that we could find them, and before they actually fell, we actually taken off all of the, there haven't been any lawsuits for prostate cancer. We've definitely caught colon cancers that were actually actively falling through the cracks, and a whole host of other things. Okay, and that's basically, these are the items that we've been looking at. Okay, now maybe I'll take 15 minutes. So I have 15 minutes. Okay, to talk a little bit. So that's what a health system, an integrated system, can do with the current wave of digital technology, but by utilizing the system and changing the delivery system structure to capitalize on the information that could be used. But the question is, still, you know, we're still seeing people on an episode basis. I mean, so we can try to hound you to make sure that, you know, we get you to do the things that we know might make a difference in your life. But the truth is that most of the things that go wrong with people are predicated many years earlier by life habits and those kinds of things. Whether you eat well, whether you use drugs or smoke or or exercise on a regular basis, arguably has much more of an effect on your health status in the long term than anything that happens on an episode basis, right? So, and so that's what we're trying to do, trying to figure out how we can migrate our system to look upstream. And so one of the things we did was we brought a lot of people in to look at, and by the way, the 4 million people, just to give you another isolated fact, you think that most of healthcare is hospital-based, right? We all think about being in the hospital, getting well, but most healthcare is actually on the outpatient basis, right? Because in our system of 4 million people, the number of hospital discharges that we have in any given year in Southern California is, in our own hospitals, is about 260,000 hospitalizations. And then, you know, we have some contracted hospitals that add maybe another 20,000 hospitalizations. So you can see that most people don't interface with hospitals, even though hospitals have an outsized influence on what we think about as the delivery system. So the question is, how could we actually integrate what we want to do with health and healthcare into everyday lives? I mean, that's really the name of the game, because, you know, it's almost too late when you see somebody coming into the emergency room with something that requires a hospitalization. We could have interfaced a lot earlier to get to those individuals. Plus the fact that there are all these new tools out there, right? I mean, you know, if you actually look at Silicon Valley, they're all trying to capitalize on some of these tools, like Teladoc. You know, if you know where you can actually call and get an online visit, either a video visit or a telephone visit with a doctor. There are all these tools that actually allow us to maybe break down sort of the geographical and temporal barriers to interfacing with people or getting care, right? You think about it, you don't have to go to the ER necessarily, depends on, you know, what the conditions are. But, you know, if you have urinary tract infection or your kid has an ear infection, you don't necessarily have to bundle that kid up and bring them down. There are all these digital tools coming online that can allow for real-time diagnosis and treatment in a way that's much more member or customer or consumer friendly, and actually can solve the problem much quicker and much more efficiently, right? So you have all of these simple tools like telephones and email, texting, those kinds of things that are available. Telehealth, it's not just, you know, video, but it actually is often telephone, believe it or not. You can solve so many problems with just telephone. Digital transmission of images allows for, store and forward type of diagnoses. I mean, for most dermatological problems, you don't really need to wait 3 months to see a dermatologist, right? If you can just snap a picture of it, send it in, and make sure that somebody actually can, who knows what they're doing, can read it and maybe interface with you either online, virtually, or however. Most of the problems, 70, 80% of the problems, could actually be treated, I think, if you did that, right? But of course, the reimbursement system doesn't allow for that, and dermatologists would really be upset if you take all their business. But remember, we're prepaid, so we can begin to do all of this stuff. And social media, right? The idea that you can leverage other people to help you, because one of the names of the games in terms of health and life integration is you want to motivate people to seek healthier behavior in some ways. Well, why does it have to be the doctor that gets you to do that? I mean, it could be your family members, your friends, so and I don't think we've capitalized on the use of social media in trying to get people healthier, right? So there are lots of things that we could be doing with that. And then, so this organizing framework is, how do we build in this life integration framework into how we do business, right? So, and I'm going to go over this very, very quickly, but we did actually work with about 1,000 people, our doctors, our nurses, frontline staff, members, and non-members alike. We brought them together, and this was a 2-year project to see how we can figure out how we can configure our system to actually get at much better results for the population and facilitate this life integration theme. So that's how many people were involved in this. And it wasn't just trivial. It wasn't like we just sent a survey out. We actually got people in the room, with flip charts and stickies and all sorts of stuff like that. Got them to generate ideas, tested it, brought them back numbers of times. By the way, we did a lot of video ethnography. If you have ever done that, it's very powerful. You just do a video interview of a patient and what they need, what they want, different kinds of patients, elderly patients who are homebound, young people on the go. And they just tell you all of the things that they need. And they're oftentimes very different than what we as healthcare providers think people need, right? You just think about it, we think we know what people want and need, but it's not always true. It's just not always true. Most people, by the way, say, it would be better if you just listened to me, right? Instead of just chattering at me and telling me all this information that I can't even remember, right? So it was an eye-opener for a lot of our doctors, and that's why it was such an incredible experience. So basically, this is where it is today. Here we are in the blue. We have this very sophisticated, we think it's sophisticated healthcare system, but we just touch a corner of people's lives, right? The domains that they live in, their social networks, it's just a tiny sliver, four visits a year if we're lucky. And if they respond to our pounding and our emails, maybe we can get that a little bit more. Well, the idea is that we take their lives and we try to integrate into our healthcare system. So it's not getting, and by the way, the healthcare system is very, how can I put it? It's very, very healthcare centric, right? It's like, you gotta come to me. You want help, you have to come to me. I will see you and I'll give you this prescription. And if you follow it, you'll do better, right? I mean, basically, I'm not exaggerating, but that's not that far from the truth, right? That's how healthcare system works. Well, in this new life integration model, it's much more embracing of our members, right? Trying to figure out what's the context for their lives and where does health fit and how can we actually find the intersection of the things that would actually make them healthier